Hey guys, I'm LaKrista with Unscripted, where we're breaking the system, finding root causes, and exposing the lies you've been prescribed. Let's jump in.
Until today, I was just like, yeah, we're just gonna go do it. You know? Like, this is what needs to be done. And then today I was like, oh shit. I think it's more of like, do I need to do it now or do I need to do it later? Because I know that they need to come out regardless, but I have zero trust in the medical system. And so being put under is actually terrifying to me, because then I'm 100% in the hands of somebody else. And I have no control over that. And so I'm like, do I have the surgery and just get it over with? Or do I wait until something happens? And then ultimately have to have surgery anyways. But I think that's more of what I'm like anxious about, is like now or later. It's not do I do it at all. It's just when. So I'm just hoping that I'll get more clarity after talking to him and try to figure out the answer to that, and hopefully feel like I can trust him to be put to sleep. You know what I mean? Because I think that's my biggest thing, is like, I just don't want to be, I've never had a good experience with the medical system, ever. Obviously, that's why I do what I do, because the whole system is corrupt. And so, whereas when you go into like the plastic surgery, I feel like it's a little bit different because it's all elective, but they're all trained the same way. So if something goes wrong, the training that they have to save you is essentially the same. So, I mean, I don't have like it's weird because I don't have like a fear of dying. I just have a fear of like not being there for my kids. That's the scary part for me, is like them not being there to raise them and be there. Like, I'm fine. Like, if I meet Jesus today, then we meet Jesus today. That's okay. But the thought of like leaving my kids and my family. So I think the biggest decision is just like when. It's just a timing thing. So try to figure that out today, I guess.
Okay, so then 2024, you started getting lateral pain.
Yes.
Did the breast actually become more firm?
No, I've always, for as long as I can remember, I have rippling, but I think it's just because there's nothing covering it. It's a saline. Yeah.
Rippling completely occurs because your tissues are just too thin on the implant. That's just like how much basically breast tissue and fat and more muscle you have on top of the implant. So yay for you, you're super fit. Unfortunately, it causes rippling. Okay, and then kids after you put the implants in?
Yes, because I was 17.
How many?
4.
So all 4 kids were after you put the implants in, which, by the way, when you have children, you typically lose breast tissue.
Yeah. Most
mothers, you literally shrink or atrophy breast tissue, which would make the rippling worse.
Yeah.
How about your weight today compared to the day of surgery, up, down, neutral?
I'm probably about 10 or 15 pounds heavier than I was then. I feel like I was bigger in the beginning. Like, I was closer to a D right after I got them done. I feel like they're smaller now. That might have been, like you said, having kids and losing some, maybe a little bit of breast tissue that I did have. Okay. Or it may just be a change in the bra that I wear. I don't know.
In general, overall, your size today compared to when you first put the implants in, like, 6 months later, once it's slowing it down, you think you're a little bit smaller now than you were back then? Okay. In an ideal world, if you could be any bra size possible, where would you like to be?
I mean, I'm happy with where they're at now.
Okay. I'm
just concerned about like the health of the implant itself and if it's causing any issues. And I don't want it to cause issues long term, Okay. So.
Okay, so symptom-wise, tell me what symptoms have kind of changed, what you've noticed over the last however many years, since you put the implants in. What's been changing in your overall health?
I mean, I'm healthier now than I've ever been.
Okay.
Like, I was actually pretty sick when I was 17,
okay.
Which shocks me that they even did the surgery. So, and then I was diagnosed, of course, which what we found out later was Lyme disease. But like I said, I'm the healthiest now than I've ever been.
The common urban myth is that you're supposed to replace your implants every 10 years. I hear it all the time.
Yeah.
My girlfriends keep telling me that my implants they're past due, they're over 10 years old. I gotta do something with them. I'm supposed to be changing them out. It's just not true. There's not a built-in lifespan. Now, it is true that the average lifespan in America happens to be around 10 years. But the two main kind of medical reasons why you need to replace an implant, number one is scar tissue buildup, which is known as capsular contracture, and number two is rupture. So capsular contracture is just a fancy term which means you develop an excessively thick bubble of scar tissue around the implant. But ultimately, that's really more of a cosmetic issue. I mean, they just turn hard. So if your implants are still pretty soft, you don't have bad scar tissue buildup. And then rupture, well, if you have a saline implant, I mean, you basically get a flat tire. They usually just deflate. It's usually really obvious if you have a rupture of saline. With silicone, more often than not, you cannot tell you have a rupture. And so it's what we call a silent rupture, where you don't really know you have a rupture. And then what typically happens is a woman gets a random breast imaging, mammogram, ultrasound, MRI, and the report comes back and says, oh, by the way, sister, we're not worried about breast cancer, thank God, but it sure looks like that left implant is leaking. And that woman usually will probably say, I had no clue. Like, nothing's changed. Size and shape, softness, everything's the same. So again, it's what we call a silent rupture. It's there, but you don't even know it. So for most women, essentially, as long as their implants are soft and they don't have a rupture, either obviously with saline or on mammogram with silicone, then basically you can leave them alone. You don't have to replace them just because they're over 10 years old. And again, that's what I call the common urban myth that's out there. I mean, let's just talk about breast implant illness. I think when you talk about breast implant illness or just the fact that you're interested in getting your implants at all, I mean, in my mind, there's kind of two parts of the conversation. There's the medical aspect of the conversation and there's the cosmetic. The medical aspect really centers around BII. What is it? Does it really exist? Any chance you have it? And then any chance you'll get better if you take them out? And then the cosmetic aspect is, okay, well, what are your options if you decide you want to remove your implant? What are your, surgical options, and what can you expect cosmetically speaking, size-wise, shape-wise, etc., if you do remove them? Medically, the conversation around BII is tricky for a couple of reasons. Number one, there's not a definitive study out there that shows an absolute correlation between breast implants and any of the symptoms that women wrote about. And I think a lot of physicians still use that as an excuse to deny the existence of BII.
Right. Yeah.
They'll say, oh, there's no study that actually, confirms this. This is just women trying to blame all their symptoms on their implants. This is no different than the 1990 Dow Corning lawsuit, where women were coming out of the woodworks blaming all their health symptoms on implants, even though there wasn't a definitive study. So I think, most plastic surgeons probably don't believe in it, but there's other physicians, rheumatologists, kind of medicine doctors who either don't believe in it or just don't really think about it. I personally have become a firm believer in breast implant illness, and for whatever it's worth, the FDA finally agrees. The FDA in 2022 put a black box warning on breast implants. So in my mind, this is kind of a huge historical shift in the conversation.
I did not know that.
Around breast implants, because for the first 60 years, we've been using implants since about 1965. For the first 60 years, the FDA is like, oh, implants are totally fine. Implants are, they don't cause any health problems. Don't worry about it. We love implants, they're great. And then finally, and this is throughout the 1990 Dow Corning lawsuit, the FDA still said the same thing. They're totally healthy, don't worry about it. There's no evidence that they cause any health problems at all. And then finally in 2022, the FDA is like, well, maybe they're not fine for everybody. I mean, there does seem to be a small percentage of women who have some health issues. A black box warning by the FDA is just their strongest warning to the American patient population for any sort of man-made medical device that we are implanting in the human body. And it basically says, well, look, this medical device works, it does what you want to do, it's going to make your breast bigger, but there's some serious health risks to be aware of. It's not completely benign for everyone. And the reason why they finally put a black box warning in 2022 after 60 years is because of breast implant illness. They said, look, we finally feel like there's enough evidence to support this concept of breast implant illness that we feel like it has to be a mandatory part of the conversation. So once they put a black box warning on breast implants, one of the big kind of changes is that the FDA essentially is now mandating that all plastic surgeons talk to patients about breast implant elements before they do a breast augmentation. Because they knew that without a black box warning, plastic surgeons just weren't talking about it. They weren't even mentioning it. They didn't want to scare patients away. Or if a patient, mentioned it, the plastic surgeon would say, oh no, there's just no evidence that exists, whatever. And by putting a black box warning, basically the FDA is like, look, Mr. and Miss Plastic Surgeon out there in the world, we essentially no longer care what you guys think, because we know that you're not talking about it. Now you have to talk about it. So any person who gets any woman who gets a breast augmentation now, when you sign your consent process, there's an extra FDA consent that you're forced to sign. It talks about all the risks, and breast implant elements is in there for the first time ever. Now the reason why I personally become a firm believer is because since the year 2017, I personally have removed over 1,100 sets of implants. I've done over 1,100 explantations.
Do you take out more than you put in?
I almost never do breast augmentations anymore.
Really?
So I do way more
Excellent.
fat grafting for breast augmentation, where I use someone's own natural tissue than doing an implant. But yeah, just in general, I do, oh my gosh. At this point, I probably do 20 to 25 explantations for every one augmentation. Out of those 1,100 explantations, most of them were women who were complaining about, weird health issues. The story typically is, I was doing pretty well before I put my implants in. I was active, I worked out a lot. And just ever since I put my implants in, I'm having more problems with fatigue. I'm tired all the time. I have no energy. I can't work out. If I do work out, it knocks me out for 24 hours. I have no reserve. My joints are hurting. My hands, my hips, my knees, everything just hurts all the time. My brain's in a constant fog. I can't think clearly from one day to the next. I'm putting my car keys in the refrigerator. I don't know what the heck I'm doing. I put the symptoms of VII into tiers. So tier 1 is fatigue, joint pain, brain fog. Almost every single woman has those three, in some degree. Tier 2 is, more of a hodgepodge. Some people have some people have others, but the ones I hear most commonly are dry eyes, dry mouth, hair loss, inflammation, weight gain, skin changes, either rashes or acne, GI issues, anxiety, palpitation. There are others, but those are probably the most common ones I hear. And then tier 3, a small percentage of women will say, oh, and by the way, since I put my implants in, I've now been diagnosed with some sort of autoimmune issue. I've now been diagnosed with rheumatoid arthritis, lupus, whatever. But the majority of women will say, I've got these symptoms. I've seen my primary care physician. Hell, I've seen 3 specialists. I've had every lab work known to mankind drawn 5 times.
And
they can't find anything. All my lab work is normal. All of my physicians keep telling me that I'm totally fine, I'm totally healthy, and that I should feel fine. And I'm, sitting over here going, well, thanks for saying that, Doc, but I feel like crap. I can't get off the couch some days, I'm so tired. Young mothers will very often have guilt, or I can't play with my kid. What's wrong with me that I can't play with them? They want to play, and I don't have the energy to keep up with them. And I kind of feel like my doctor's acting like I'm crazy. But I know my body. I used to work out a lot. I know what it's like to be tired from working out too much. This is different. There's something different going on in my body that is affecting my lifestyle, and I just cannot wrap my head around it. But it's completely affecting what I can do, lifestyle-wise, working out, and I just want to feel better. That is typically the story I hear. And out of 1,100 plus explantations, a crazy high percentage, 80 to 90% of women will come back 3 months later and be like, oh my God, I feel so much better. I have more energy, I can work out again. My joints, don't hurt as much. My brain, I can think more clearly. The rheumatology thing is interesting because the only lab value that we'll sometimes see out of whack is an ANA.
I mean, I was ANA positive for a while.
So,
I'm not now, but...
An ANA is a generic inflammatory marker. It doesn't tell you what's going on in your body. It just says you have inflammation in your body.
Yeah.
Not why it's there or where it's coming from, which is generic ANA. So an ANA is very often elevated in various rheumatologic issues, lupus, rheumatoid arthritis, Sjogren's, Hashimoto's, whatever. And so it's not uncommon that a woman will have an ANA and then a chronic care physician sends her to a rheumatologist. And I've had a couple of patients who will come see me and they're like, yeah, I saw a rheumatologist, and even the rheumatologist was like, well, your ANA is positive, but the rest of your
like CRP
lupus workup and RA workup is negative.
Mm-hmm.
So I'm not really sure what it means. And then some women are like, well, but then my rheumatologist is like, look, even though your lab work is not showing that you have classic RA, your symptoms look like RA, so I'm just going to treat you like you have RA. And I've had a couple of women talk to me, and it's been 3 years, and they're on strong immunosuppressives, steroids, methotrexate, Remicade, Plaquenil. These are not benign medicines. They decrease your body's ability to fight infection. They decrease your body's ability to heal from wounds. And these women show up several years later and I'm like, look, I've been on all these medicines. I still have joint pain. Like, they're not working. And then we took their implants out, and as women came back 3 months later, I'm like, holy crap, I'm off of all my medicines. My joint pain's gone. That woman never had rheumatoid arthritis.
Right.
What she had was a set of symptoms that was kind of acting like RA, and the rheumatologist unfortunately just didn't think about it. Now, luckily, the times are changing. I mean, I talk to patients now, and they've talked to rheumatologists. Rheumatologists are much more open to the thought, like, hey, have you thought about, thinking about taking out your implant? Is it possible that it's the implant?
Yeah.
One of the challenges in trying to diagnose breast implant illness is that there is no preoperative lab test we can run. There is no lab test that says you have breast implant illness. The only way you can truly diagnose breast implant illness, unfortunately, is to take out your implants and see if you feel better.
Yeah.
So obviously someone has to feel pretty crappy if they, especially if they cosmetically like the way they look in their clothing with extra volume, to take out their implants. If you believe that breast implant illness is a real phenomenon, then I think the next logical question is, well, what's causing it? Why do most women do fine with implants, but a small percentage have these weird symptoms? We don't know for sure, but there are 3 prevalent theories that are out there, and one of them just makes a lot more sense to me than the other 2. So the first theory is the contaminant theory. Could I somehow have mold, bacteria, something, kind of growing around my implant that's making me feel sick? I am sure there's a picture on the internet somewhere of an implant with like black mold on it. But after doing 1,100 of these, I can tell you that is 1 in a million. That is not what you typically see. When you take out an implant, I don't care if it's been in there 40 years. Almost always, that implant looks brand new normal. It doesn't have black mold on it. It just looks fine.
That's what I just told him. I was like, one of my biggest concerns is they're going to take these out. They're going to be full of mold.
I mean, again, it's out there on the internet, but that is not what we see. And I've swabbed around the implant for cultures for mold, bacteria, and you almost never find anything.
Okay.
So I don't really believe that's probably what's happening for most people. Second theory is probably the most common, which is just the classic silicone toxicity theory. Mm-hmm. Could somehow the heat in your body breaks down the silicone in the shell? Because even a saline implant has a silicone shell, right? So there's silicone no matter what. And so could the heat of your body break down the shell, and the heavy metals that go into making a silicone implant, could they leach out in your bloodstream and make you feel sick? That theory sounds a lot more plausible to me than the mold contaminant theory. I'm like, all right, I could see how that could happen. But unfortunately, when you look at all the data, it doesn't really add up. I mean, there's some things that don't add up. For instance, if it was a silicone toxicity theory or a problem, why do only about 3 or 4% of women have breast implant illness? Well, why wouldn't it be way, way higher if every single implant out there has silicone? Why wouldn't the incidence of breast implant illness be way higher?
Yeah.
Also, if you look at the bloodstream of people who have breast implant illness, you can find someone who actually had breast implant illness, they took out their implants and they got better, like, okay, well, you probably have breast implant illness. And you look at their bloodstream, there's no silicone or heavy metals in their bloodstream at all. On the other hand, you can look at someone who doesn't have an implant in their body at all, and that person has heavy metals and silicone in their bloodstream.
Well, I've done a total tox panel. I do them every 3 years, like I was saying with my Lyme panel. So I check for all of that.
Okay,
so
why would the woman who has no implants?
Yeah.
The reason is because all sorts of beauty products that you use, lotions and whatever, have silicone in them as well.
Yeah.
So, that doesn't quite, make sense. Also, there are, people who don't even have an implant in their body and have similar symptoms. Hold that thought, because that kind of helps support the third theory. The third theory, which is what I believe most strongly in, is what I would call the autoimmune foreign object hyperinflammatory response syndrome. I think this is probably unlucky genetics more than anything. If you take someone who is genetically predisposed to autoimmune issues, which, by the way, your chance of getting an autoimmune disease as an American woman is 3 to 4%. That is the lifetime incidence of autoimmune diseases for American women. And that's almost the exact same percentage of women who get breast implant illness. But basically, if you take someone who's just genetically predisposed to autoimmune disease to begin with, you've got some sort of defect along the DNA code, and then you put a foreign object in your body, I think more likely than not, your body just doesn't like seeing that foreign object. And so your own immune system just gets kind of revved up where it's fighting that foreign object. And so your body is in a state of chronic inflammation thereafter. Hence, some women have these ANAs that are positive. Mm-hmm. And then you take the implant out, and your body no longer sees that foreign object. The inflammation settles down, and you feel better. So again, you look at people who have other foreign objects in the body, dental implants, abdominal mesh from 20 years ago, even plates and screws from broken bones, hip joint replacement, etc. Those people have very similar symptoms, or can have joint pain, fatigue, etc. None of those things have silicone in them, but they're creating similar symptoms. The commonality is that they're just a foreign object that could also be creating weird inflammation. So as I add up all the pieces of the puzzle, that theory makes the most sense to me. Now, of course, I could be wrong. I mean, there are people a lot smarter than me who are looking into this, but that's the theory that kind of checks all the boxes for me. I'm like, yeah, okay, that adds up, and yeah, that adds up, and that makes sense. So that's kind of what I think is going on. So if you say, okay, look, I'm ready to, I want to feel better, I'm willing to do whatever it takes, well then again, unfortunately, the only thing you can do at this point, if you've exhausted all other options, is take them out. Now, here's another challenge with breast implant illness. I cannot promise you, or anyone else, even if they're having these symptoms, that taking out their implants is going to make them feel better.
Right. Yeah.
I do not want to overpromise or oversell what an explantation can do for someone. I don't want to feel like a snake oil salesman, like, oh yeah, you take them out and you feel 100% better. Yeah, guaranteed. And with someone like you, I think it's even more of a challenge, because you have a medical diagnosis that could explain your symptoms, your Lyme's disease.
Yeah.
The person who really has no medical diagnosis and their lab values are normal, but has fatigue, joint pain, brain fog, I mean, that's the person I feel kind of most confident that taking out the foreign object breast implant is probably going to make them feel better. But admittedly, it's more of a challenge. Well, it's more of a challenge, first of all, for anyone. Who's to say that's just not life?
Yeah. It's really the only symptoms I have, I'm severely ADHD. I don't remember being that way as a kid. I was straight A student. I did really well in school. But I'm just is it because now I'm an entrepreneur and I just this is life, and I have brain fog, but I'm also, is that because I have 4 kids and I run a business? You're a working mom with 4 kids and, But I'm not expecting
working
any
out
of that.
Blah, blah, blah.
Yeah, and I'm not expecting any of that to go away. I think I'm just looking more long-term health.
Okay.
It is a foreign object. I do have this history of autoimmune. So just long-term, obviously I think the smart decision is just to not have a foreign object in your body with that history, you know what I mean? But
well, for any woman who is worried about breast implant illness, again, I cannot promise that taking out that implant will make that person feel better. The 2 things I can promise you or anyone else who chooses to remove implants, number 1, I can guarantee you your back and neck will feel better immediately. Taking out your implants is basically like a breast reduction. You're removing a certain amount of weight from your anterior chest wall that is pulling on your upper back and neck. So upper back pain, neck tension, shoulder shot grooving, even headaches, because neck tension may trigger headaches. That's guaranteed. I mean, most women within 24, 48 hours will come back and like, oh my God, my back and neck feels much better immediately. Or oh my God, I can stand up straight again. I'm not being pulled down by the weight of the rolls. I mean, that has nothing to do with breast implant illness at all. That is simply weight. You know, the bigger the implant, the more it weighs and the more relief you're probably going to feel. Second thing I can promise you is that if you remove the foreign object, taking out an implant is not going to make you feel worse.
Right.
It can only make you feel better. I mean, taking out the foreign object is not going to make your inflammation worse. It's not going to make your fatigue, joint pain worse. It can only make you feel better. Now, whether or not it makes you feel better or to what degree, basically only time will tell, but sure as heck not going to make you feel worse. All right. So again, if you've gotten to that point, you're like, look, I'm willing to try, or I'm just done with my implants. I just kind of want to be healthy. That kind of transitions more to the cosmetic aspect of the conversation. Okay, if you've come to that conclusion, I'm ready to get them out, then, again, it kind of begs the question as well, if I do remove them, how much volume am I going to have, what are they going to look like, etc. What are my options? Okay, there are really two main decisions when you're going to do an explantation. The first is breast lift versus no breast lift. And the second is in-block versus regular capsulectomy. Okay, so when you take an implant out, you're going to go in there, you're going to remove the implant. Because I believe this is a foreign object problem, I want to remove 100% of the scar tissue capsule that has formed around the implant. So you're going to remove the entire capsule, it's called a capsulectomy, but all that scar tissue is gone. If the implant's below the muscle, I need to repair the muscle because your pectoralis major is supposed to be attached to your chest wall. When the surgeon puts the implant in, they basically divide the inferior attachments and kind of hinge the muscle up and put the implant below it. So if you take the implant out, your muscle is just kind of flat and breathe. So I'm going to basically reestablish your natural anatomy. Sew the muscle back down to your chest wall. That way, when you work out and flex the muscle, it doesn't like pull on your breast tissue and make the breast tissue bounce, which is a fun party trick, but that's not what's supposed to happen. So sew your muscle back down your chest wall. That way when you work out, the girls don't move. And then again, at that point, the question is, okay, well, at that point, do we just let your breast tissue bounce back on its own, as well as it can? Or, upon examining 5 minutes, do we both agree that there's some loose skin already right now? And when you take the implant out, there should be more loose skin. You got a certain amount of skin, which is being basically inflated by the volume of the implant. And so when you remove the implant, you've got the same amount of skin, but now you don't want anything below it. You should have created basically more loose skin. And so should we basically remove that extra skin and make the girls as high and tight and perky as we possibly can? Most people benefit from lift. I mean, everybody's different on the exam, but most women have had implanted for a while, that skin's been stretched out, or like you, they've had 4 kids since then, and that kind of stretches out your skin even more. And so more often than not, a breast lift is helpful. And when you talk about a breast lift, that means you're going to remove some skin, which means you're going to put a scar on your body. The goal of a breast lift is basically to raise the volume of your breast up, so you don't have that skin-to-skin contact with your breast, raise the nipple up so the nipple is, well centralized, pointing straight ahead, not down low, make your areola smaller if you need to, and kind of make the girls high and tight and perky such that when you lie on your back, they stay here, you don't fall to your armpit. But the trade-off is a scar. So there's 3 main patterns for a breast lift. I only offer 2. So there's a donut pattern, that means you scar on the areola only. There's a lollipop, which is a scar on the areola and then down. And then there's an anchor pattern, which is scar on the areola and down, but then you get this big scar that goes below your breast. I don't do an anchor. An anchor is an older technique. It's been around since like the 1950s. The lollipop has only been around since 1999. So there's still plenty of surgeons who do an anchor, and it's not wrong. It's just an older technique. But that scar below your breast is just not necessary. You do not need that big scar below your breast. And I think it's kind of paradoxical because the lollipop has less scarring on your skin, but it actually internally has much better support. So I think the lollipop is kind of best of both worlds. Less scarring on your skin, but better internal support. So for me, basically if you have a little bit of loose skin, donut. If you have a moderate to significant loose skin, lollipop. Okay. in block versus total capsulectomy. I mean, it's an important conversation because I think there's probably the most amount of potential misinformation on the internet regarding this subject. There are plenty of people who will say, "Oh, you have to do an in block if you want any chance of feeling better, or if your surgeon doesn't do an in block, you're not giving yourself the best chance of improving your symptoms, etc." This is the biggest study to date done on breast implant illness. They followed 3 plastic surgeons in different hospitals around the country and looked at whether or not an explant made someone's symptoms get better, and then whether or not it mattered whether or not they did an in block or total capsulectomy. And the data in that study matches mine to the number. That is to say that the woman who has these weird symptoms, but otherwise, work is pretty much normal, 80 to 90% of women do notice an improvement in symptoms when they get their implants out. But it does not matter whether or not you do a total capsulectomy or an in block. The rate of improvement is exactly the same.
What's the difference?
A total capsulectomy means that you take out, well, let's go backwards. An in block means that you remove the implant and the capsule as one solid piece. Like basically you don't even see the implant,
right? Because
it's all contained within the bubble scar tissue. So it comes out like this intact dinosaur egg where you've got the calcified scar tissue around the implant, but you don't even see the implant. And a total capsulectomy means that you dissect around the capsule as much as you can, but at some point while the implant's still in your body, you make a cut in the anterior capsule, you reach in, you remove the implant, then you wash out the inside of the capsule, you clamp the capsule shut, then you finish the dissection around the back side of the capsule and remove the capsule. So either way,
it's all still coming
100% of that capsule is coming out.
Okay.
You don't have to do an in block to remove 100% of the capsule. The difference is it coming out in one piece with the implant, or is it coming out in 2 pieces? But either way, it's all coming out.
Okay.
And again, the data shows that it does not seem to matter whether or not you do an in block or a total capsulectomy. Your rate of improvement is 89% either way. What probably matters is that you actually get rid of the capsule.
So with in block, it's just the fear of releasing something that's in there?
Exactly. So I think that people on the internet who are most adamant that you have to do an in block to give yourself the best chance of feeling better. My suspicion is those people either believe more strongly in the contaminant theory or the silicone toxicity theory. Like they are so convinced that they either have mold around their implant that they don't want to be released when you're dissecting the implant, or that the implant itself is just so toxic, again, the silicone toxicity theory, that they don't want the implant to touch their tissues even for a half a second when you pull it out. But if I'm correct, and this is just a foreign object problem, then that makes sense why it probably doesn't matter whether or not you take the implant out or the capsule out in 1 piece or 2 pieces. What matters is that all of the foreign material is gone by the end of the operation. And again, that's what the data seem to confirm.
Okay.
Now that being said, it is true that I always try to do it in block if I can. I mean, I always try to get it all out in one solid piece, especially because like if someone has a rupture, it'd be nice, it's like with silicone, it'd be nice to contain it. So I always try to do an in block. And if someone's implant is above the muscle, I almost always can do an in block. It actually is usually almost always possible to do an in block if it's above the muscle. If it's below the muscle, you almost always can do an in block. The problem is that the capsule's stuck to the rib cage. And so either it's just going to take a really long time or the capsule is just too darn thin and it just breaks at some point. So even if you try to in block, there's no guarantee you can't, because your capsule ranges from, a scar tissue capsule starts off like a soap bubble. It's translucent, it's like 1 cell thick, completely soap bubble thin, and then over time it gets more thick and calcified and it turns into like a solid chalk white calcified scar tissue capsule. Well, if you have a soap bubble thin, translucent, capsule, and it's stuck to your rib cage, basically imagine a soap bubble that's stuck to a sponge, and you're trying to separate the soap bubble away from the sponge with a knife without popping the soap bubble. Good luck. Like sometimes it's just not physically possible. It's just too darn thin and friable. Also, to do an M-block, you need a much bigger opening. You need a much bigger skin opening to get the implant out.
Gotcha.
So if you're doing a lollipop lift, you almost always can do an M-block. If you're doing a donut, you can do an M-block and get a really small implant, but if the implant's bigger than 250, 300 milliliters, it's probably not going to work. And if you're not doing a lift and you're just trying to go back through someone's prior scar, you would now have to make a really big scar below your breast to get the implant out as an M-block. And again, it takes more time. So that's more time that you're underneath anesthesia, more time that your brain is soaking in anesthetic gases, and the OR times money. My fee, anesthesia fee, hospital fee, everything's based on time. So you're spending a lot more money to do an M-block as well. So again, I'm just adding up all the pieces of the puzzle. In my mind, I'm trying to give someone the best medical chance of feeling better. But if medically speaking, the data shows that either way, total calcium versus M-block give the same chance of feeling better. But I can save you an hour of anesthesia time. I can save you $1,500 extra money for the surgery. I don't have to put a bigger scar on your body than necessary. So cosmetically, it gives you a more favorable, result. And in my mind, if you have to do total calcium, then okay, fine. It's going to be fine. It is outpatient surgery, no matter which way you do it, lift or no lift. I work here. I've got a quality certified OR on the back half of this building. I also work at OU Edmond. I have privileges at lots of hospitals in Oklahoma City, Mercy, Integris, Oklahoma Surgical Care. The problem with most hospitals in Oklahoma City is that since COVID, they have become stupid expensive for self-pay plastic surgery. They have jacked up the rates so much that it's just not really cost effective. So either here or then they're still cost effective. But you have to go home. I will call you that night and check up on you. I will give you my personal cell phone number. Call me 24 hours a day if you need me. I'm going to see you the day after surgery. You will have a drain. The drain comes out at 1 week. I'll see you at 3 weeks, 3 months, 6 months if necessary, definitely 1 year. But I'm going to see you a lot. I'm not going to operate, and then the next day they're like, okay, well, you look great, later, good luck. Final cosmetic result is about 3 months down the road. Typically the shape gets better over time. Essentially the shape of your breast is its absolute kind of worst right when I finish operating. Because your skin is maximally stretched out as soon as I take the implant out. That skin does bounce back. So even the day after surgery, it looks better than at the end of surgery. And then it looks better at 3 weeks, and it looks better at 3 months. The shape gets better and better and better. My goal is to get the rolls as high and tight and perky as I possibly can, such that whatever your volume is, let's make it a high and tight and perky version thereof. I can't control your volume. That's one thing I cannot control. I can only work with whatever volume you have to give me, but if it's an A cup, let's at least make it a high and tight and perky version thereof. Now there are 3 possible, what I call less than ideal cosmetic outcomes that can occur when you take an implant out. You don't want these things to occur, but they can. The answer for all 3 of them, the cosmetic backup plan, is fat grafting. Fat grafting is where you come back 3 months or later down the road, you liposuction fat from any place you don't want it, which typically it's love handles. You take your own fat, you spin it down, and you re-inject it. And you can get upwards to a cup size depending on how much fat you have. Now, you may not have a lot of fat, you're pretty fit. So if you don't have fat in your body, fat grafting doesn't work very well. But if you have some love handles and you can donate them, well then you can get upwards to a cup size of extra volume. So problem number 1 is the girls just aren't big enough. You take them out, you go back to an A cup, and you're like, well, I didn't think I was gonna miss that volume, darn it. I kind of do. I don't necessarily need to be as big as I was. I was a C cup with my implants in, but I'm a moderate A now. If I could just get a little bit more volume, if I could be like a small moderate B, I think I would just fill out my clothes a little better. I think we'll be a little bit happier. Okay, great. 1 session of fat grafting, get a cup size, you've gone from moderate A to moderate B. Problem solved. Problem number 2 is you lack upper fullness. Honestly, that's called being a mom. That has nothing to do with the implant at all. That's called being a mother. When you have children, more often than not, you lose volume in the upper half of your breast tissue. That's why a lot of them put implants in to begin with. Like they've had 2 kids, the girls shrink down, like, well, I just want to regain that upper fullness. Or sometimes, like you possibly, you put an implant in first, then you have your children, you may not even know that you lack upper volume at this point. But when you take the implant out, it's going to show up. Again, it's not the implant's fault. A pre-baby breast is basically a teardrop shape. You know, thin up top, full on bottom, but it's more or less a straight line coming off your chest wall to the nipple and the curves underneath. A post-baby breast, no offense, it's kind of a ski jump. It's kind of just scooped out. It's just kind of flat up top and it kind of scoops out. Even if you do a breast lift, I mean, it can kind of help, but if that volume's gone, it's gone. And so if it shows up when you take the implant out, if you're like, I just don't like the fact that it's kind of flat up top, well then great. You know, put some fat in and give yourself some more upper fullness, problem solved. The third problem is, you know, you can potentially get like a crease or a fold in the skin. That is most likely in someone who is an A cup, and like smaller than a small B cup, and or if they put a really big implant in. You know, the person who doesn't have a whole lot of breast tissue underneath the skin, they've got a big implant, that person's mainly skin. And when you take the implant out, especially if they choose not to do a lift, that skin, as it's stretched out, as it falls back, it can just sometimes fall in on itself and create like a little crease, and there's no breast tissue below it to kind of push it out. Well, if you go back and put that in and kind of, you know, push from below, that crease can kind of unfurl and get away. So again, fat grafting is the backup plan. You don't want to do fat grafting at the same time that you take the implant out because there's not good blood supply. Fat grafting needs good blood supply to survive or else it just dies. Even in the best case scenario, you expect half to survive and half to dissolve. That's not a complication of fat grafting, that's the norm. That's the expectation. But if you do a fat grafting at the same time that you do an expectation, you might get like 10%, you know, survivability. So it's kind of a waste to try to do it at the same time. You want to take the implant out, plus or minus do a breast lift, let the blood supply return to the breast tissue, and then 3 months later, if you do fat grafting, well, the fat's going to actually survive. Okay, medical risk of surgery. Bleeding, hematoma, 1% chance. If you bleed, you have to go back and wash things out, so that is an inconvenience, but it's not going to change the result in the long run. You just got to deal with it. Infection, 1% risk, same thing. Inconvenience, take you back and wash it out, not going to change the result in the long run. Wound healing, you're not a smoker, correct? You don't use nicotine, you'll do fine. Even if you have a small wound separation, and most times you leave it alone and let it heal back in. It doesn't really change your result in the long run. Alteration with nerve sensation, 5% chance. All right, you can get, when you talk about nerve changes, that can be numbness, or it can be hypersensitivity pain. It can actually go completely opposite directions, not just numbness you got to talk about. But I think nerves are probably one of the trickiest parts of this operation for me as a surgeon, because anatomically speaking, when your nerves basically, they exit your outer chest wall, they kind of go through your rib cage, you know, up through the muscle, through the breast tissue, and then, you know, up to the skin to supply sensation. So when the surgeon puts the implant in, they basically push your nerves to the side, they make a pocket below your breast tissue and or muscle, and then they put the implant in. Okay, so those nerves get pushed off to the side. I promise you, your nerves have kind of fallen back, and they are now basically stuck to the side of your implant, or more specifically, they're basically stuck to the capsule. So in order for me to get rid of the implant, but also get rid of the capsule, I literally have to separate your nerves from the capsule to get rid of that capsule. I know exactly where the nerves are located. They're not going to jump out and surprise me. I'm not going to be operating and be like, oh crap, I just, you know, ran across a nerve, damn it. I know exactly where they're located. The challenge is that I'm essentially trying to separate a thin, wet noodle that is encased in a sheet of concrete without tearing the noodle. It's just darn tricky. I mean, nerves are tiny little fibers, and there's a shite ton of scar tissue wrapped around them. So I'm going to very carefully just and kind of chip away and, you know, separate that nerve from the scar tissue. And 95% of the time, it works out just great. 5% of the time, that nerve can be cut, it can break, it can be burned, it can get cauterized, you know, it can be damaged. And that can create numbness routinely. Now, the good news is, even if you have some nerve damage at the beginning, the majority of the time, if you just leave it alone for 6 months to a year, breast nerves do have a good way of healing. They just have a good way of kind of slowly waking up. So even if you have some numbness at the beginning, what typically happens is that month after month after month, like the surface area, the amount of skin that's numb, just gets smaller and smaller and smaller. And a year later, like, oh, just kind of slowly kind of woken up. So yay. The bad news is I can't help you out. There's nothing I can do after the fact to make that nerve wake up any faster. Just tincture time with your best friend. Okay. I think that's about it.
Okay.
Questions, concerns about breast implant illness as a health phenomenon, options for surgery, recovery, risks involved?
I think my question is, and I'm about 90% sure I will not do this, but I think the thing holding me back is like, okay, I get a reduction with the surgery. What happens if you go, is it possible to put implants back in after you've had that?
So anatomically, absolutely. If someone does an explantation, and then down the road, just cosmetically speaking, they're not happy, redoing the augmentation is not a big deal. Remember, I've completely reestablished her anatomy when I do the explantation. I've sewed her muscle back down, I put her right back where it was, I sewed all the tissue back up. So to redo an augmentation, that's kind of similar to a primary augmentation. So it's absolutely possible. For me, the bigger question is, what happened symptomatically when we took your implants out? So if someone comes back and sees me 3 years later, and they're like, oh yeah, I had fatigue, joint pain, brain fog, 3 years down the road, I've noticed no changes. Nothing's changed. I had the exact same amount of fatigue, joint pain, brain fog. Then I think the conversation will go, okay, well, we tried. It doesn't seem like anything got better, so you probably didn't have breast implant illness. So there's no kind of medical reason why you shouldn't put the implant back in if you want to.
Right.
Go for it. Now, if the woman comes back 3 years later and she's like, oh yeah, my brain fog is a lot better, my joints don't really hurt anymore, but I'm just cosmetic, I'm not really happy, I want to put the implant back in. My response would probably be like, you're probably gonna need to find another surgeon.
Yeah.
There's no way that ethically that makes any sense to me. You just proved to me that taking out the implants medically made you feel better.
Yeah.
So you probably did have breast implant illness, which again in my mind probably was caused by a foreign object. So why would you want to put the foreign object back in at this point if you kind of prove that symptomatically you did get better? I would definitely try to encourage that person to do fat grafting. Now if that person's super fit and doesn't have gut panels, well then it's a tricky conversation, but I personally would not put the implant back in.
Okay.
Any other questions?
I don't think so.
Okay. All right, well grab your stuff, let's go back and do an exam and we'll go from there.
So I just finished up my consultation, and ultimately his recommendation was that I don't need to do anything, because I'm not having really any BII symptoms, and even though I'm having sometimes I notice a little bit of, it's not really, I wouldn't even call it pain on the left side. He's like, there's not really a significant amount of scar tissue, I think everything's fine. But he said I'm kind of in the gray zone of once they do an explant, if that's what I decide to do, that he's like, some people, I'm like, you definitely are going to need a lift, and other people I'm like, no, you're fine. He's like, you're kind of in the middle. He's like, but with saline, he's like, I want you to just come in a month before and we'll just do lidocaine and just drain them, and then you can go for a month. I was like, you're just gonna, he goes, yeah, we just put a needle in there and just drain the water into a bowl, and you just sit there for 30 minutes while they drain out. And I'm like, okay. So I definitely, if I'm going to have it done, I think I'm definitely going to do that. So that way I can determine if I think I'm going to need a lift or not. But, afterwards, he doesn't like to put implants back in. Obviously, he said he does mostly explants, but he was like, you're definitely not a candidate for fat grafting. So he's like, congratulations, you're really fit. You don't have any fat that I can take. And so I guess usually they do it from your back, because your stomach's stretched out from having kids, but they said you don't want to do underarm, inner thigh, because then it just leaves skin. The skin laxity isn't there for it to bounce back. So he's like, you can do it, but then you have another problem after that. So he's like, you don't really have any skin from the areas, or any fat in the areas that we typically like to take, unless you want to go eat ding dongs for a couple months and put on about 15 pounds, and then we can go from there. And I was like, well, typically when I gain weight, I don't gain it in my love handles anyways. So I really don't think that putting on 15 pounds would make a difference. It would probably just make my thighs bigger. So I'm not going to try that. So that was really the only like letdown I had, is that once I get them out, there's not another option for me with him anyways. So I guess we'll just see. But that was really, I think, the only surprising thing to me is he was like, you don't have any, like, that's not an option for you. So I think that was the only thing that really shocked me. But
okay.
Because I was like, seriously, like my thighs, I'm like, you can't take anything off of those? And he's like, he goes like this. No. I was like, okay. But anyway, so I guess I'm going to go home and try to go through all the details and then all of the invoices, price differences, and kind of see if we're going to do this now or if we're going to wait until nature takes its course and we're obligated to remove them later.